Excellent. This meeting is being recorded because it is a public meeting, and it will be posted on our committee webpage shortly after the meeting's conclusion. For everybody's reference, the agenda for today's meeting can be found under the first tab of the meeting materials. And Judy is out today, Dr. Zerthal, so in her absence, I am going to turn it over to John Staloff, who will now call the meeting to order. John.
Thank you so much, and good afternoon, everybody. As mentioned, I will be walking a mile in Judy's metaphorical shoes today. Welcome to everybody, and thanks so much for being here. I now call the Advisory Committee on Primary Care to order, and thank you so much for joining today. If you could open your presentation to tab 1, you'll see the agenda for the day. First, I will go over the agenda, and then we'll begin with roll call. After roll call, we will vote to approve the meeting summary of the July committee meeting. Then afterwards, we will open the floor to public comment. Afterwards, Summer Boslaw, a transformation analyst from the Oregon Health Authority, will give a presentation on Oregon's primary care payment reform strategies. Afterwards, Shane Mofford, who we have met several times now, from the Center for Evidence-Based Policy, will provide some additional high-level context around primary care payment policies. And then lastly, the committee member, Michelle Cosley, will provide a brief report out to the committee on United Healthcare's perspective on and experience with reaching the primary care target set in Rhode Island. I strongly encourage committee members to ask questions and provide feedback to help facilitate our discussion. And thank you all so much again for your time and for your insights. I'll now begin with roll call. I'll call on members by first name in the order listed on the agenda, which is in alphabetical order by last name. When I call on you, please unmute your microphone and let us know that you're here, and then please mute your microphone again. All right, so Crystal.
Here.
Great, welcome. Sharon.
Present, here.
Wonderful. Tony.
Here.
Great. Michelle.
Here, good afternoon.
Good afternoon to you. Nancy.
Oh, Nancy is not going to be joining us. We're taking care of that. So thanks, John.
Okay, thank you. Tracy.
Tracy was in the waiting room and I just re-added her as a panelist. So I think she's rejoining shortly.
Okay, wonderful. David. DC.
Yeah, hi, I'm here. Thanks.
Wonderful. Good to have you here. Sharon Eloranta.
I'm here. Hi.
Hi. Gregory. Chandra. Meg.
I'm here.
Hi, Meg.
Hi.
Cheryl. Lan. Kevin. Eileen. Katina.
I'm here.
Hi, Katina.
Hi.
Mandy.
Mandy is out today. She let me know in advance.
Okay. Next is me. I'm here. Sarah. Linda.
Hi, good afternoon.
Good afternoon to you. Sean.
Present.
Stacy. Ginny. And Maddie.
And I am here as well. Hello.
Hi. All right. Thank you, everybody. I will turn it back over to Jean Marie, who will facilitate review of the July meeting summary.
So much, John. And if everyone could just join me quickly in turning to the meeting summary and the meeting materials. The recording of the last meeting was posted to our webpage. Does anybody have any discussion points of the currently displayed meeting summary or proposed changes? Would someone like to motion to accept the summary?
Hi,
So-
DC Dugdale here. I move to accept.
A second?
Second,
Any further discussion? If not, all in favor say aye.
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 Any opposed? And the meeting summary is approved by consensus. Next, we are going to go ahead and open the floor for public comment. When you are called upon, please state your name and affiliation, if any, before speaking. Don't raise your hand more than once, please. This ensures that everyone has an opportunity to speak. You're also welcome to provide any comments in writing via email at any time. Please also keep in mind that this is the time for public comments. Any Q&A sessions during the meetings are for committee members to ask specific questions of the presentations. So this is your time to shine if you're a member of the public or not a committee member. So with that, anybody have comments they would like to offer? Go ahead and raise your hand and we'll allow you to speak. Okay. Not seeing any hands. I don't think I'm missing anything. Anybody seeing anyone that I might not have caught? No? Okay. All right. Well, I know that Summer, who's giving the presentation, was telling me she had a Zoom update that she needed to make on her computer. So Amy, who's on from the Oregon Health Authority, do you know, is she good to go yet? Is she on? I don't see her on.
Hello, everyone. No, Summer is having some technical difficulties with her Zoom, as she mentioned. So she did hop off and she's going to log back in. So I don't know if there's another agenda item that maybe you could go to while she's managing that.
Shane, we could skip to the piece that you have, but I think we were hoping to really follow that chronologically from Oregon's report out.
We could do the introduction piece if you want. Part of the introduction is just talking about the strategy for getting the members the information they need to make informed policy, and Oregon is part of that. So if you want, we can.
Yep, we can flex and kick some of that off to begin with if you'd like.
All right. Well, thanks everyone for being flexible on that. So what I'll be talking about in more detail later today is just a little bit of background on where we're at in the process for developing recommendations, what the strategy is to support you in making those decisions, and then a few pieces of context that are really the direct result of our conversation last time, just to all really help build a solid framework of understanding around the implications for some of the policy recommendations to make sure that things are feasible and that ultimately we have really solid recommendations. So just to take a step back, we started, I believe it was back in June, or it might have even been the month prior, and we started this process of creating a general framework of, well, what are the pieces that move to get you to a 12% target? And there's multiple domains. It can be direct investment in expenditure, reducing expenditure on other things. So for example, if you're implementing pharmacy cost controls, that's going to reduce your denominator, which could increase your numerator, or excuse me, increase the ratio. But all of that culminated in soliciting a list of initial ideas that were predicated on a combination of examples from other states that we walked through in detail, as well as some ideas from committee members. We took those general ideas, and in our last meeting, to help drive the conversation forward, we turned those general ideas into more specific policy recommendations. And the goal of that was to really help us understand what direction you wanted to move from those general policy recommendations to more specific policies. And we needed to get over that step so that we can then start to understand, well, what type of information will you need to flesh out that policy? What are some of the key types of data or information that would be needed? So we're going to, based off of those conversations and where we landed with some of the more specific policies, support you in getting that information. And we have a couple of different strategies that include things like getting speakers from other states. Oregon's a great example. We're very fortunate to have them come speak about their experience. Also looking at data and all of that. So we're really going to be focusing on making sure that you have the right information to really craft a tight, realistic, feasible policy. So just as a reminder of what we got into in the last meeting, some of the key points that came out of that conversation is that action is required to ensure primary care is being funded sustainably. The committee members definitely communicated a sense of urgency on the topic, but also that it needs to be grounded in reality. It's going to take time to achieve a 12% target. States like Rhode Island, for example, they had to close the gap from, I believe, 5 to 10% in a 5-year period, which is a pretty significant lift. We'll hear a little bit more about that from one of the payers' perspectives later today. Also, that there was additional information desired to really frame the reasonability of those targets over time. And that's part of what we'll be talking about today as well. I want to note that we won't have statewide estimates using the new primary care definition until after the 2024 data call. So any of these conversations today, they're really just to help you get a sense of how some of the mechanics work when setting a target over a multi-year period. And they're not at all about getting to a specific recommendation or voting in the immediate term. So we'll have to work on a strategy by which we close the gap between those two concepts. Like, how do you continue to make progress while recognizing that you do have some information gaps in the shorter term? And then members also wanted to know what the outcomes were from other states that have implemented similar policies. So it's one thing to invest in primary care and to have aggressive policies such as trying to achieve a 12% expenditure target ratio. But it's another thing to validate that you got an increase in access or that you sustained access. And yet another piece of the puzzle is whether or not you're getting the outcomes that you want for that investment. So I think we're really fortunate to be able to tap into the experience of other states to ask these types of questions, and we'll be able to start with that today. And then the last piece, if you take a step back and you think about, well, what do you need to craft a recommendation for a 12% expenditure target policy? It's really broken into, or you can think of it as being broken into two pieces. So there's the structural piece, which is how far do you want to work towards achieving each year, over what time horizon? Who are the actors that have an accountability for achieving those targets? So really that structural piece of the policy. And then the other piece is also connected back to the legislative mandate that you have, which is figuring out, well, what are the mechanisms by which you incentivize the carriers and payers to achieve that target? And we talked about examples from 3 different states that included, and these are kind of ranked from how big of a stick you use it progressively. So an executive order that wasn't necessarily binding, a legislative mandate that was binding, and then also action through the Office of the Insurance Commissioner. So again, you have the structural pieces of the policy recommendation, and then you have the levers by which the policy would be implemented. And ultimately, this is what you're going to have to figure out. So we recognize that we're going to have to support you by making sure that you get information, not just on how you craft the expenditure targets and the timelines, but also the mechanisms by which they could be implemented. So that's just a little bit of a tee up for some of the detail that we'll be getting into later. I'm going to take a quick check to see if Summer joined.
So we're encountering some difficulties. She's on by phone, but I don't know how to get her to be a panelist, Shane. So
Actually, pardon me. I do see Summer as an attendee. Her name is not listed. It's an OR number, which is a state identifier, probably through her phone. So it's OR 071956 as an attendee. So I don't know if you could make that person a panelist.
I can.
Oh, okay.
Great.
All right, we'll hand it back then, and we'll talk to you soon. Thank you.
That she did.
So can you hear me now?
Ian. Hi, Summer.
Okay, great. Sorry for the technical difficulties. I got a new computer today that I was not anticipating, and everything seems to be going haywire. My name is Summer Bozzo. I'm with the Transformation Center with Oregon Health Authority. We sit within the Health Policy and Analytics Division of the agency. Next slide. So just a quick overview of what I want to share with you. And my colleague, Amy Harris, is on the phone as well. Can pipe in if I miss anything, Amy, or be available to answer questions. She's been really involved in this work as well. So talk about our primary care payment reform policies. I can tell you a little bit about our value-based payment compact that interacts with this work in a positive way. The primary care VBP model that was just developed by a collaborative that is managed and staffed by OHA, and some of our lessons learned. Next slide, please. So in 2015, Oregon passed a key piece of legislation that laid out the work for our primary care payment reform efforts. This bill, Senate Bill 231, did two things. It directed OHA and the Department of Consumer and Business Services to report each year on healthcare expenditures allocated to primary care from Medicaid, public employee benefit plans, and commercial health plans. OHA also added Medicare Advantage, since that's data that we have available in our all payer, all claims database. The primary care spending in Oregon report is for the legislature, but it's also published on the state of Oregon's website. It's a tool that's been used by policymakers, interested parties, and OHA staff to track primary care spending by payer. And then the second thing that Senate Bill 231 did was directed OHA to convene the multi-stakeholder primary care payment reform collaborative. The collaborative is, as I said, it's a multi-stakeholder. It's an advisory group charged with. Sorry, I'm still having technical difficulties. Here we go. I'm charged with assisting Oregon to develop and implement a primary care transformation initiative with the purpose of increasing investment in primary care, improving the reimbursement for primary care, and aligning primary care reimbursement across payers and purchasers. There are more than 30 members of the collaborative. And the group has been convened since 2016. The legislation was influenced by several factors. Oregon had been monitoring similar work in Rhode Island, as you're aware of their work. We have an established patient-centered primary care home program. My colleague Amy Harris is actually the manager of that program. And then there was extensive advocacy from primary care provider organizations that there needed to be more measurement of primary care spend and increase in spend, as well as change and alignment in payment. And that we had legislative leadership who championed the bill. Next slide, please. So in 2017, the legislature passed another bill that strengthened the prior bill of Senate Bill 231 and further defined the primary care spending report and the collaborative to support payment reform efforts. This bill requires payers to allocate at least 12% of healthcare expenditures to primary care by 2023. Payers who don't meet this target have to submit an improvement plan on how they will increase their primary care spending by at least 1% each year until they meet that target. The 12% primary care spending target for the legislation was based on national research indicating that 12% primary care spend is needed to support a robust primary care system. And in this bill, that primary care transformation initiative, which is the work of the Primary Care Payment Reform Collaborative, was also further defined to include using value-based payment methods, supporting behavioral health and physical health integration, and aligning metrics in the strategies. It also extended the end date for the collaborative to 2027, with expectation that the goals of the initiative would be completed by that time. This bill also, you'll probably note by the timing that it came after CPC Plus was started. And so also within the legislation was there was a great desire to expand the access to and impact of CPC Plus across Oregon. We had about 150 primary care practices that were participating in CPC Plus, and the legislation called upon those payers, who were already participating in CPC Plus to expand make that same payment model available to all of their primary care practices, not just the 150 CPC Plus practices. And then it called upon payers that were not participating in CPC Plus, or CPC Plus actually was not named specifically, but it was described, and that payers that are not implementing the CPC Plus payment model or anything or something like it to do so, and to do so with and make it available to all of their primary care providers. Next slide, please. So in addition to the work focused on primary care value-based payment, the Oregon VBP Compact began in 2021. It grew out of Oregon's focus on creating a sustainable sustainable cost growth target for healthcare in Oregon, and that the initial activity or action that could be taken by payers and providers and policymakers to bend the cost curve is to implement value-based payment. And so the value-based payment and that there should be a compact that would be established to which would be signed on to by payers and providers to commit to a set of targets to increase value-based payment across all settings of care, and then a specific at an HCP land category or of 3A or higher, so that's shared savings, and another set of requirements or targets for shared risk or higher, specifically for primary care and for hospitals. And we have 47 signatories, including commercial payers, all the Medicaid plans, Medicare Advantage, health systems, and clinics. And the signatories represent 73% of Oregonians that in the state. Signatories also include provider organizations such as the Oregon Academy of Family Physicians, Oregon Medical Association, Hospital Association, our Primary Care Association, and others. And the purpose of the compact was to increase the use of value-based payment to lower the rate of cost growth, foster health equity, and improve quality and outcomes. And the compact, to achieve that, the compact is looking at expanding innovation, learning from early adopters, removing barriers to value-based payment, and expanding knowledge and awareness. And the first task of the compact work group was to develop a roadmap. The roadmap detailed challenges, barriers to implementing value-based payment, and proposed strategies to overcome those barriers and challenges. Next slide, please. So the lessons learned, and I guess we moved around the specifics of the the primary care value-based payment model. So I know we really wanted this presentation to focus on what Oregon has done to set and ensure that payers meet that primary care spend target of 12%. But I can also describe the VBP model that has just recently been developed and for primary care, if that's of interest. So the lessons that we've learned, that it's important to establish an active relationship between the committee, in our case, the collaborative, the Primary Care Payment Reform Collaborative, and the Primary Care Spending Report. They came out of the same legislation. The spending report is always presented to the collaborative, but the collaborative does not have any isn't the owner of the spending report, and does not can propose or suggest changes or new modifications to the report, but those aren't decisions that are made by the collaborative. And so if we were to do this again and going forward, it would be really helpful to have that connection relationship be more active, be more defined. That the one component is that being able to define primary care in rule. There is a rule defining primary care in Oregon for the purpose of the report, but it was not, and some people that are engaged in the collaborative were engaged in defining primary care, but it is not, they're not, they don't overlap completely. And so it would be really much more beneficial to aligning the work were there to be a clear role for the collaborative or the committee in setting and maintaining that definition of primary care. And then in terms of actually, developing the report and implementing the report. Again, as I said, there's not a defined role for the collaborative in creating and implementing the report, and we would definitely recommend to make that connection clear and defined. That it would just really strengthen the role of the committee and the impact of the spending report. Also, something that we have not done is setting a goal that increasing primary care spend, so trying to get to that 12%, that when you do that, it should be in a value-based payment model. That is not, I think that's what we hope within the work of the collaborative, but it is not, is not defined in that way, and that is a lesson learned that would be helpful going forward. And then also to set the goal that the implementation of a primary care VBP model should increase primary care investment, and using the spending report to measure impact. So really being more mindful about connecting the measurement of primary care spend to the payment models, and to increase both, in alignment. Next slide. Okay, so there's links to the primary care spending report and the primary care payment reform collaborative. I'm happy to go into kind of a quick overview of the details of the primary care value-based payment model that the collaborative completed a couple of months ago. I guess let me know if that would be helpful, or if you want to stop here and ask questions, or I'll leave that up to you.
Committee members and Shane, I think you also, we talked about teeing up some questions, so if you have anything you wanted to direct folks to as well.
Hi, this is Sharon, and I would be Sharon Alaranta, and I would definitely be interested in hearing a few details
If
about
anyone is
the
speaking, I
model.
can't hear them, but oh, I know why. I'm sorry. Okay, I think I should be able to hear people now.
Oh, sorry, this is Sharon Alaranta, and I would say I would be very interested in hearing some high level details about the value-based purchasing program if we have time for that.
Sure, great. I can launch into that, or Shane, I see your hand raised.
No, please go ahead. I will. I have a follow-up question if that's okay.
Okay, great. Yeah. Okay, next slide. Keep going. Next one. There we go. So the primary care BBP model that was developed by the collaborative. Here's just a high-level overview. It is a prospective capitated payment model for a defined set of primary care services, and we've got a list of all of those codes. These are ones that are widely performed by practices, and the representing a preponderance of primary care spending. Outside of those codes that are part of the capitated payment, there are fee-for-service payments for all other covered services. And then there's an infrastructure payment that includes a required base payment tied to PCPCH tier. That's our patient-centered primary care home. And right now the program has 5 tiers. And so that the amount of that per member per month infrastructure payment would increase at higher tier levels. And that 2, there are additional payments that for specific high value services that are optional. And when we were looking at creating this model, that prospective capitated payment covers about 85 to 95% of primary care services. That percentage varies a little by payer and by age group. And a sample of some of the codes that will be paid fee for service, and we left some codes there to encourage utilization. There are some behavioral health codes, home visits, prenatal visits, end of life and advanced care planning, as well as some after hours codes. So that's the kind of the high level of the payment model, and the next few slides give a little bit more detail. So around participation, attribution, and the payment rate. So the collaborative spent about a year meeting monthly to develop this payment model. And actually, before I go any farther, let me tell you a kind of a little so the value-based payment compact, as I was said, was part of the cost growth target work, and was signed on to by senior leaders within health systems and payers and provider organizations. And they one of the barriers that they identified to expanding value-based payment is the abundance of value-based payment models. And again, they're looking not just primary care, but across all settings of care. And so to address that barrier, they want to create a short menu of models. And the first model they identified was the need for a primary care BBP model that could be adopted across payers and providers. And they looked to the Primary Care Payment Reform Collaborative and asked, we think this is a valuable tool to increase value-based payment. The collaborative said, yes, we agree. And the compact work group said, great, you have a lot more expertise in this than we do. You've been doing this for a long time. Can you develop a model? And so the collaborative said yes. and they established a work group that met for about a year to develop the model. So that's, you know, the connection between the two. So the model does not require PCPCH recognition. Again, that's our patient-centered medical home program for initial practice participation, but that it must be obtained within 3 years. The group decided that there should be no other participation requirements, so no requirements of number of patients and size of practice. The goal is that all practices that contracted with a payer will phase into the model within 3 years. That all patients will be attributed or assigned and prioritizing patient choice, and that the prospective payment rate would be set by analysis of historic per member per month spending. Next slide, please. So risk adjustment. There was a lot of conversation. I'm sure that this is no surprise to folks. How you adjust for clinical, age, gender, social risk is really important. The group decided that that demographic risk adjustment is needed at a minimum, so age and gender. That clinical risk adjustment, when it's used, there should be separate methodologies for adult and pediatric populations. That it should be used in total cost of care arrangements. That it is optional for the prospective capitation payment, and that it could be used for some of the infrastructure payments. And the considerations around using clinical risk adjustment for that prospective capitation payment amount, there are considerations in favor of using clinical risk adjustment. That adjusting payments based on clinical risk score can help ensure a more accurate estimate of how much it will cost to care for a patient population. And those risk-adjusted capitated payments will reflect the relative clinical risk of the patient panel that could result in higher capitated payments to providers who treat those patients with greater healthcare needs. There are also limitations of using a clinical risk adjustment for a primary care capitated payment. The kind of predominant one being that there is not a commonly accepted methodology to estimate how much primary care someone needs based on their medical condition, and that prospective payment rates that was recommended that they could instead be calculated based on historical utilization with an additional payment increase to compensate for capitated procedure codes that were not historically reimbursed by a given payer. So that then, that capitated payment would cover more codes than maybe some payers had been reimbursing. And so you could look historically to set rates and then add an additional payment, assuming this kind of assumes that patients with greater healthcare needs are using healthcare more. And so their historical utilization would bear that out, and then that would be factored into the risk adjustment. And then you could use the clinical risk adjustment for certain infrastructure payments, and they were thinking that the risk adjustment methodology, if you're to do that, should include some parameters, including ensuring a limited amount of variance on payout amounts based on risk scores, that payers may limit the use of clinical risk adjustment to only apply to infrastructure payments that entail care management or other services involving support for patients with higher medical complexity. So really tying the use of those infrastructure payments for services that patients with greater healthcare needs might be using. And then there was great discussion and interest in social risk adjustment. And the group decided that for the purposes of moving forward with a model, that they wanted to set social risk adjustment aside for the completion of this payment model, but to convene a subcommittee to develop a pilot going forward. And so that group will begin meeting towards the end of September to establish principles to guide their work and develop and recommend a pilot to the collaborative. Next slide, please. So performance-based incentive payments. This is another area where the group is deferring to a subgroup who will come back to the collaborative with recommendations on an aligned measure set with a balance of child, adolescent, and adult-focused measures. These measures will come from and align with work already being done in the state and measures already selected as a larger menu set. It was recommended that the total size of the measure set should not exceed 8 measures. It'll be interesting to see when that work group also convenes at the end of September, how that plays out. That was really a push from providers, that there should be at least one equity-focused measure, that practices should be rewarded for both meeting benchmarks as well as improvements over time, and that the total eligible incentive payments should be at least 10% of the value of all service payments. Next slide. And then the infrastructure payments. Again, there's one required that's based on that PCPCH tier, and then additional payments could be agreed upon by a payer and a practice, including additional case management or care coordination, integrated behavioral health services, traditional health worker services. This could include community health workers or doulas, integrated pharmacy, services to address health-related social needs, actual, infrastructure, technology, and staff, specifically around the collection of race, ethnicity, and language data, and sexual orientation and gender identity data. And then innovative equity-focused services, such as funding for bus fares or for patients with transportation needs. And final slide. Promoting equity. This was really important for the group in all of the development of all aspects of the model. That they could support practices to stratify quality metrics by race, ethnicity, such as with an infrastructure payment. Particularly, this could be an infrastructure payment that supported technology and staff to be able to collect and analyze that data. Higher payments could be made to practices that serve patients with higher medical and social complexity through adjusting the risk adjusting. Include one or more equity-focused measures in the measure set. Consider using improvement targets. So some of these I've previously stated, but kind of wanted to bring them all together in a slide focused on promoting health equity. Infrastructure payments that could address health-related social needs, and strategies to protect against unintended adverse consequences of value-based payment, which could include discouraging a panel of high morbidity patients or making too many specialty referrals. And so that there are strategies within the model that are specific to each of those, such as paying an increased fee-for-service payment for care delivered outside of normal care delivery hours to incentivize expanded access, so that you're to try to address the possibility of withholding or limiting care, to avoid discouraging panel of high morbidity patients. You could it's possible to adjust payments so that practices that treat patients with higher medical and social complexity are paid more. And in terms of making the possibility of practices making too many specialty urgent care and ED referrals, that a payer could track patterns of specialty care, urgent care, and ED use and discuss any observed patterns with practices. They could also incorporate total cost of care as part of a practice's incentive payment where feasible and appropriate. So that is the summary of the model. Where we are now is trying to communicate the model out to various audiences and hopefully getting the model in use. We're also looking as an agency, our role as a purchaser to incorporate this model into our contracts with the coordinated care organizations, our Medicaid organizations, as well as our public employee benefit and Oregon educator benefit boards plans, and also consider looking into what could we do with the marketplace as well in the future. So I will stop there and happy to answer any questions, and Amy is on as well. Jane. Back to you.
Hey, thanks so much. First off, I think this is just such great information as we're trying to figure out, ultimately what is the recommendation for implementation. And it's great that you were able to make the connection between value-based purchasing and the targets, because that's something that we've been talking about. And it's really front of mind as making care primary is coming on board at the federal level too. So there's just so many moving pieces, and hearing your thought on that was really helpful. So I just wanted to say thank you. I did want to take us back to and just really lean in on the lessons learned piece as you were crafting and getting prepared to implement the expenditure targets. In addition to the recommendations that you had were there any other key lessons learned, such as, man, I really wish we had looked at this aspect of potential impact or unintended consequences before we implemented? Like, for example, I think it's easy to recognize that there are just a lot of moving pieces in that 12% statistic, access and utilization and pricing across every single service. And so there's a lot of uncertainty that you can't solve for on the front end. But any key lessons learned on what you might have looked at had you been given the opportunity prior to implementation?
Yeah. Good question. Amy, do you have anything that comes to mind beyond what I shared?
Yeah. So Oregon's definition of primary care is partially in statute and then partially defined in rule. And so, and then also operationalized at the state level through our health analytics staff when we look at coding. So there's these multiple layers of how we define primary care. And as Summer said in our lessons learned, we did a pretty good job at engaging community partners in that work, but we could have done much better. And so I think really making sure that there's support and consensus as much as possible across all those different aspects of how your primary care is being defined, because then of course that will feed into that target. And so if you have a good, solid, again, as much as possible consensus on how primary care is being defined and how you're tracking it, it will be much easier to accept those targets because folks understand what's in there. And our methodology does change a little bit from year to year as CPT codes kind of come in and come out. We made some adjustments because of COVID in terms of adding telehealth services. So there is some adjustment that happens year over year. But I think, again, having that really solid consensus as much as possible on the front end would be what I would definitely recommend.
Yeah, and what Amy is implying is that there's been pushback on sort of all sides and about what's in that definition and what's not in the definition. And it's been interesting to do some analysis of what it would look like if things were, some things were out or in the definition, and actually the changes would not be that significant, but the optics are pretty significant. And so yeah, I think just a robust consensus process to set that. And I don't know, Amy, what, you know, Amy has actually been more involved in this, and then producing the spending report. Amy, is there any issues with the fact that it's in statute and rule? Does that pose any, would you have any recommendations?
Well, I mean, statute's a lot more difficult to change than rule, right? So, I mean, I would say as much as you can, I mean, you know, that would be my only comment. Like, I mean, you know, it's just more difficult. We have not been, we have not changed our statute since the bill was passed in 2015. We have had different advocate organizations that have talked about wanting to put bills forward to change that statute, but that hasn't happened. So we are really sort of confined by what's in statute for our definition, which again was in 2015. So really early in this work, there's been a lot of growth and changes since that time that we haven't really been able to you know, modify our definition of primary care in a way that we might want to because of that statutory definition. So, and there hasn't been a strong will to change it.
There's been a lot of interest, but not enough.
Yeah,
not enough aligned interest.
Yeah,
to make that change.
For sure.
Jonathan?
Hi, thank you so much for this presentation. It's really wonderful hearing the details about the value-based payment model. I think of primary care investment and value-based payment models, primary care or otherwise, sort of two sides of the same coin. One is we need to increase investment in primary care. That's the one side. The second side is, and once we do increase investment, we need to make sure we're paying for value and making sure we're supporting population health and health equity. I would love to know more about the first side of the coin of we need to increase investment in primary care before we talk about, okay, how do we actually pay for it? In one of your slides, you mentioned that payers were required to increase investment by 1% per year. And if they weren't reaching a certain threshold, they needed to sort of report a plan. I'd love to know more about what statutory or regulatory authorities Oregon had in place to actually hold payers accountable to increasing primary care investment before we even get to the payment model. So what would happen if a payer didn't make that investment, didn't place a report? What regulatory or statutory authorities were in place to make sure that that accountability was baked in?
Yeah, good question. So it varies for who you're talking about. So for Medicaid, for the CCOs, we have more authority, although you know, we can put things in contract or, you know, change contract to add requirements with the public employee and Oregon educator benefit boards. There is more leverage there. Again, it's OHA, you know, at the state as a purchaser. For commercial, they're required to report. You know, we evaluate what they're spending. If they're not spending enough, then they have to submit a plan that they will improve. And if the next year comes around and they have not improved by 1%, we don't have, you know, we don't really have it. There's no teeth to the legislation to, you know, to make them do that. Amy, am I misspeaking? Please correct me.
Right. So that's actually a really great question, because we haven't actually started requiring those improvement plans yet, because it's just now 2023. And there's actually a bit of, we're actually having a bit of an internal discussion right now as we speak, because our data in which we use to calculate our primary care spending is from 2021. It's our APAC data, our All Payer All Claims Program data. So we're questioning, okay, so is this the year that they're held accountable, meaning 2023, or is it really in 2 years when it's the data from 2023 versus the data from 2021? So we're having this internal discussion. We're actually getting ready to like craft some rules. We're getting some guidance from our government relations staff on what that exactly means. So, so right now, the way that the legislation is written is it really just is an improvement plan. And that's across the board for both OHA, so both our Medicaid as well as our commercial plans. It's just an improvement plan. We don't, which would be folded into our annual primary care spending report. So we would report on not only who is meeting that target, which we already do every year, but also what are they going to do to improve that. So far, that's all we have. That doesn't mean that we won't have something else in the future. It just kind of depends on what the legislators are and kind of what the will is, what the legislators are going to take a look at when they're seeing those payers that aren't meeting that target. Is there going to be some advocacy to put a little more teeth behind it? Maybe, but we don't know yet because we just now are starting to, again, implement that actual requirement. So, but as Summer said, as it's currently written, there really is no teeth, so to speak. It's just an improvement plan.
Got it. Thank you so much for that answer and for your candor. I appreciate it.
Yeah, of course.
Sean?
Thanks. Actually, I think Tracy might have had her hand up first.
Okay, Tracy. Sorry, Tracy.
I was gonna switch back to the definitions. Sean, did yours kind of follow on from this? Do you want to go first?
No, mine's separate.
Okay. I was just curious around the definition piece. I do think it's so important. I've really gone back and forth in my own mind because we're using pharmacists in some pretty innovative ways. But can you say a little bit more about, did you feel your definition was too broad or too narrow in terms of what was included, or was it really just sort of that optics piece? And then can you share maybe what groups you were having trouble with, and so we might not make the same mistake?
Amy, I'm
Sure.
going to turn that to you. Amy
Yeah,
really
no.
led
Yeah,
this
so
work.
so I'll just say I am not the methodology expert on this report. I've been working on the policy side, not the methodology side. But I can tell you that two of the key sort of sticking points for the definition of primary care in Oregon is the provider type. So we included in statute both OBGYNs, because there was this idea that they often serve as primary care providers for a certain period of time in a person's life, particularly a person that's pregnant. And we also included psychiatry. And the reason we included psychiatry was because we were really trying to capture behavioral health services that were happening within primary care. So we have these two providers that even from an operational standpoint, when we layer on like the service location, which is part of our methodology. So we look at where the service is being provided and the service type. So what type of service and where are they being located? We're not capturing necessarily exactly what we're trying to capture. Although, as Summer said earlier, we did do some analysis to see what would happen if we backed out those two provider types, and it's not a huge change. But there is this perception of, particularly from the primary care provider community, that we're just not, that those two provider types don't really belong in the definition of primary care. And then on the other side, there's actually not only primary care providers, but behavioral health providers who feel like there are different types of behavioral health providers that definitely should be included, like licensed clinical social workers, or even peers in some way, or LPCs, really those folks that are providing the behavioral health services often in the primary care practice, which we also are not capturing. So I would say most of our discussion has really been around the provider type. There's also been a bit of not pushback, but unhappiness, I guess, from the providers about how we are including pharmacy, because pharmacy is actually not part of our definition. And so there's some feelings that at least some pharmacy should be. And so that's also been a bit of an issue. So, and I can drop in the link, or I can drop in the chat, or I can send it, the report that describes all of our methodology and some of these challenges that we've had in past reports as well, if you're interested in taking a look And
Yeah, that's
it has the
incredibly
codes.
helpful.
Yeah.
Yeah, that's incredibly helpful and so interesting too, because in our system, OBGYN and behavioral health are both part of primary care, which is under my purview, and that's always been a discussion point.
Right. Yeah, for sure.
Sean?
Great, thank you. First, I wanted to say thank you. This is a lot of heavy lifting on your part. I think we can probably, I'm sure we can benefit from the information that you're sharing, the work that you've done. So thank you. And then Amy, if nobody's really happy with you, that means you're probably doing a good job. So, but my question is, there's two questions. One is the reference you listed, would that be where I could find things like attribution methodology and credibility thresholds and some of the more details? Would that be in the link that you listed, or how might I find those details?
I'm not sure what you're
on the slide that says the additional information. I think we linked to the primary care spending report, and we also linked to the
collaborative.
The collaborative. So yes, I would. Yes.
Okay, great. I appreciate that. And then the second question is, are there any stipulations or regulations or requirements that the recipients of the funds, the people who either are or employ the primary care providers, actually spend those funds toward primary care? Or is that left to the discretion of the organization?
That's left to the discretion of the organization. Yeah. So they could be, and correct me if I'm wrong, Amy, I think that, you know, a CCO, for example, could have care coordinators or, you know, case managers employed by the payer, and that can count in their primary care spend. So it is hopefully the helping members, but it's not money that goes to the the primary care practices. And this, you know, you could say similar for large health systems, that, you know, they might be spending additional on primary care, sort of at the system level, but it doesn't mean that, you know, that rates payment are higher to individual practices, you know, within the system or individual clinicians.
Right. Great. Thank you very much.
Crystal.
Sean, that's a really good question. Just because I've been thinking about, as we've tried to improve training on Epic tools, have been sort of some key strategies, but it's really expensive to do that. So it'd be great to be able to think about how to use those resources.
Echoing what everyone said, this has been extremely helpful. So thank you. I appreciate the work that you guys put into this on an ongoing basis. One of the things I've been grappling about with a little bit as we've done this work is the data, and the measurement is so key through all of this, right? Even the examples you gave of where there is some, you know, disagreements or discussions that continue to happen, you've been able to quantify that pretty clearly. So can you speak a little bit to us? I'm not sure if you're the right folks or if you can share some information. How did you resource that? How did you resource the analytics that are so key in making sure that, you know, we're understanding these decisions as we're building it, and then can quantify that later after we've built it, right?
Yeah, so I think you're speaking to the analytics behind the reporting.
Yeah, and as you were developing, like we're in the early stages, right? So how, as you're making those decisions on the provider type, place of service, that kind of thing, that's going to become so important. How did you resource that early on?
Yeah, well, I'll just say that it has been a lot more than we thought in terms of staff time. And we're actually in the middle of conversations right now about ways to reduce the staff time that it requires. I mean, it requires a lot of a pretty senior analyst position within our health analytics program. Amy, I'm going to let you say more about it because you've been involved from the beginning.
Yeah, so like Summer said, the data, so it's sort of two parts. It's setting it up at the beginning, right? So figuring out what those codes are going to be, how we're going to operationalize it again through actually using the data. But there's also a lot of ongoing work year after year to do the actual analysis. So we're lucky in that we have our all payer, all claims data, and that captures both our claims-based spending, but also our non-claims-based spending. Our payers report non-claims-based expenditures through that same system. So we do have all that data kind of in one place, but it takes a lot of work to really stratify it. And while we're developing the report every year, we have an analyst who spends about half his time for about 6 months of the year just working on this report. So it is really time intensive. It is really time intensive. But for Oregon, we feel like it's worth the investment. We are looking at some ways to perhaps streamline the report to make that data analysis a bit simpler for our analyst who actually does it. To sort of take a little bit of the burden off of him, but it is really time intensive. It actually used to be more time intensive when we actually created a actual PDF of the report. Now it's a Tableau dashboard, which has made it a bit easier. We don't have to actually create charts and things like that. It all happens magically in Tableau, but it is a really time intensive. And again, it's also done with all internal staff. I should say that as well. We don't use any contractors. It's all state of Oregon staff. So we've allocated the resources to that.
Yeah,
And
thank you.
one thing I'll add is that, you know, a big part of that challenge is identifying who's a primary care provider. We do not have a statewide provider directory. It would make a big difference if we did. So, and I don't know if that's something Washington has, or is that, you know, in the future. But again, yeah, really taking all the data and then identifying who really is a primary care provider is a challenge. Shane.
Hey, one of the questions that was raised by committee members in a prior discussion was seeing if there were any lessons learned about some of the outcomes from this additional investment in primary care. And I think that could maybe even take 2 tracks of outcomes. So patient outcomes, health, and then the other is really on the cost front. So given that there's just so many levers that you can pull to achieve that 12%, and it isn't just a 100% increase to provider reimbursement, it can be difficult to really understand what the fiscal impact will be. So do you have lessons learned both on the client outcome front and then on the fiscal front? So for example, did you have to invest a lot more money in your CCO's managed care rates in order to have this policy be effective?
We did not, right, Amy? We did not, did not impact rates. And I think in terms of being able to measure impacts, there's not a direct way to do that either. Which would be, I know, if you could figure out how to do that, it would be a great addition. Now, what we can do now is see, year over year, what the spend looks like, by payer, but we don't know, where is that going? Who gets those additional dollars?
That makes sense. Thank you.
I will say that that we did. I think, Amy, I've got it right that the first year was blind, payer blind, and then it's been, we named the payers, which it's helpful to have payers know that their name is out there associated with with those numbers. And if you look at the averages, for example, the as a average, the coordinated care organizations, the Medicaid plans are spending, are meeting that 12% target. But if you look at the individual plans, there are some that are not there, are pretty far from there. And so, it's valuable to have it public, although I'm not sure that that's, it hasn't driven a whole lot of improvement over time. So anyway, something to think about. Linda?
Yeah, thank you. Well, I was wondering if there was any look at workforce and as far as filling that in relation to so of course you're looking at all there's going to be a continuous look at population health, but I was interested in your workforce providing primary care, and if there's any mechanism by which you're measuring that, measured it before, and are looking at that and attracting into primary care, whether it be obviously in behavioral health or otherwise.
We do a workforce analysis report, and Amy, do you? I feel like I don't know a lot of details about it.
So, so yes, we do a workforce analysis report. We also, just in this most recent legislative session, passed several investment in our workforce bills that actually helps with like loan repayment programs for both behavioral health providers and physical health providers, and actually it's oral health providers as well. So we have a whole bunch of new funding that's coming in that our legislature passed to help retain and attract those providers that we just now are starting to develop the implementation for. I'm not really familiar with that work. It is in the same department as me, but I'm not as familiar with it as I should be. But I can certainly connect you with the staff person who is, and even send you some of that information on that report. But I guess to your question, it's not directly a part of this work in terms of the primary care spending or in terms of the value-based payments. Other than we do know that those practices who are getting those additional funding, they do use them for providers, particularly providers that aren't that can't bill. So we do know at least that some of those additional funds are being used. We know that anecdotally. So
Okay, thank you.
Well, thank you so much, Summer and Amy, for coming. This has been a really fruitful discussion, and your presentation was very informative. So I know if folks have additional questions that they can send them directly to you all. I can get that to you, and very happy to have you. So thank you so much.
Great. It's pleasure to be here, and I think we've done and continue to do great work in Oregon, and there, as we've shared, there are things that that we could do differently, and happy to help others as you're starting in this work, to maybe bake in some of the things that would be different and more, and make you perhaps more successful going forward. So I'm happy to answer any questions in the future. Great. Thanks.
thank you.
Welcome to stay for the rest of the meeting if you'd like. It's totally up to you. But at this point, I think I'm going to turn it to Shane to resume his piece on policy context, which should flow nicely from this state discussion. So we'll just pick up where we left off.
Yeah, absolutely. So I think we can actually go to the next slide. Just as a quick reminder, so we're going to just continue to do some of the level setting and exploration of this topic to help ultimately inform the recommendations you'll be developing. I know that it was just so great to follow that, actually, because a lot of the concepts that we've talked about definitely rang true from the Oregon experience. I guess that's the advantage of not living on the bleeding edge too, is that you can learn from peer states. And clearly it was a big lift. So we're going to be talking really about three concepts that are stemming from our last discussion, and they're really just to help level set. But I have a really big caveat before we dive into those concepts. which is that a lot of these concepts we're illustrating just through kind of a thought exercise versus actual data. And part of the reason for that, it just goes back to you have all of these different domains and different levers within those domains that actually influence where your primary care expenditure ratio lands. And it's not just about direct investment. In fact, I think it was really interesting that it sounded like the CCOs were able to achieve the 12% target, although not universally, as they noted. But the state didn't add in additional investment directly. So I think that may be worth exploring. But it just highlights that this equation is pretty complicated. So just keep in mind, even though the examples are going to be really focused on direct investment, and that there's more to it than that. And we've talked about all of this in the past. So I know it's in the back of your mind. I just wanted to resurface it. If you could go to the next slide, please. Thanks very much. This first concept is just thinking through a little bit, going back to some of the points that were made in the last meeting about the urgency for ensuring that primary care is sustainable, particularly on the coattails of COVID. I know that you all gave several examples of facilities closing down and losing staff and early retirement and all of that. And when we started to talk about the percentages, we didn't have a clear example at the time in front of you that was just illustrating kind of the relative magnitude if you were only looking at increases in direct investment to make progress towards 12%. So we thought it would be helpful to just draft a simple example that illustrates how there is a pretty big difference in magnitude here between a 1% increase in that total expenditure ratio, like the percent of primary care as a percentage, or the percent of primary care spend compared to the total, and what the corollary change in reimbursement would be. And this both has an impact when you're thinking about feasibility, but also in terms of what more shorter term relief might look like, to the extent that that's even a possibility. So what you see here on the far left of this example, this is a general approximation of the percent of primary care spend compared to all other services. In this example, it's 5%. You just heard Oregon say 7% based off of national standards. The OFM report, it actually had a range of where that status quo is, depending on whether or not you used the narrow or the broad definition. And then, of course, keep in mind that even the OFM report didn't have complete information because it didn't have some of the non-claims-based expenditures, which means those statistics, even under broad or narrow, would likely be higher. So this is strictly to just illustrate the concept of differences in magnitudes between 1% increase and the impact on primary care expenditure. And this is in aggregate and holding everything else constant. So under the scenario of going from 5% to 12%, you can see that the actual change in primary care reimbursement, if this was the only vehicle and nothing else was moving, is a 140% increase, so more than double. And that makes sense because you're going from 5 to 10% is a 100% increase, and then 5 to 12% is an additional 40%. So I think, again, this is just to highlight that when we're talking about a 1% change in primary care expenditure as a percent of total expenditure, that the actual impact on primary care is going to be much more significant. Just because that 7% number was referenced from Oregon, just some back of the napkin math, to get from 7 to 12%, it's something like 72% increase, which would translate to around a 14% increase annually over a 5-year period. So again, just to really ground our thinking, I know there's a sense of urgency given the post-COVID impact, but a 1% increase actually translates to a significantly larger increase for primary care if you're just looking at direct investment as the mechanism. Any clarifying questions from this example or any reaction before we move on to the next concept? Okay, great. Next slide, please. And another concept that we want to hit on here, the policy that we've been really focused on is kind of that macro policy, which is kind of all payers that are included in the pool should be working towards 12%. As part of that initial exercise where we gave examples of different state policies from across the country, and then we solicited ideas from the committee just to get to those general ideas for potential exploration, there were Medicaid-specific recommendations. It's, I think, an outstanding policy question that we're not going to get into today, but do you even need a Medicaid-specific policy if you're implementing a broader policy like that macro policy? If you have macro policy, do you need micro policy? But one of the points we want to highlight is that if you're focusing on individual payers, that it really shrinks the magnitude of the impact while focusing the cost on that payer. So, for example, if you were to, and again, this is just an example based off of some rough numbers. These aren't real. The relative percentages are from the OFM report, but the example is totally fabricated. This is just to illustrate the concept that some of the micro policies aren't going to have as big of a bang for a buck as you might think, even though the numbers for that individual payer would be quite large. So if Medicaid is reimbursing at 65% of Medicare in aggregate, this is approximately what we found in the Kaiser Family Foundation report that we talked about previously with you all. And you were to increase reimbursement to 100% of Medicare, because Medicaid is estimated to be 31% of total primary care expenditures. While it's a 54% increase in reimbursement, it's only a relative approximate 17% increase in total primary care expenditure, where would only be moving the bar from 5% to 5.85%. So this kind of highlights the concept that if you go too far down the rabbit hole on micro policies, you do run the risk of introducing some distributional impacts. And I know that when we were working through principles, equity was definitely one of the considerations. I think that was more focused on providers in all fairness, but I think the general concept applies. If you could go to the next slide, please. So in the first example, we made a really aggressive assumption to make the point of the difference in relative magnitudes of a 1% increase in the aggregate expenditure target versus the direct impact on primary care reimbursement, which was that we're holding everything constant. And that is just not the reality. The reality is that you have a very complex dynamic of changes in utilization patterns for all services and changes in price patterns for all services. And there's going to be lots of drivers under each of those two factors as well. What you see here, based off of National Health Expenditure Highlights report from 2021, it's just a sampling of trends for inpatient, outpatient pharmacy, and physician clinic services. And you can see that healthcare expenditure trends are different by category, as I assume you would expect. And you can see that some of the trends are actually quite high. Pharmacy, not surprisingly. We've seen a lot of these very high cost innovator drugs. We know on the horizon, some of the new weight loss drugs, they're going to be expensive and in high demand, for example, and that's going to drive trend. The point that I want to make here is that because these things, because your 12% expenditure target happens within a very dynamic environment, there's really two key conclusions to take away from this. One is that it can make it difficult to hit the target if you have runaway trends on all of your other services. I think one of the things that we're likely to hear about when Rhode Island comes in to share their experience, which I think will be equally as helpful to the Oregon experience, is that they did things to help mitigate trends in other categories as part of their global effort to really improve that expenditure distribution in their state. So that'll be interesting to learn about. The second, so it can be difficult to achieve those targets when you have aggressive growing trends in other service categories that disproportionately impact your total expenditure. Tracy, you had a question?
Yeah, sorry. Can you remind me, our pharmacy is drugs in our bucket that we're measuring?
I would have to double check. For the example,
Okay.
I didn't check to do.
Okay, because I was just curious, like, for example, Ozempic, we're just seeing, I mean, it's exploding. And certainly it's going to help people's A1Cs and such, but it seems like we could get really out of sorts of counting that as primary care when it's a drug expenditure.
Right. And that kind of highlights the point of you have really complex dynamics but under the hood, even though it's a really simple statistic of 12%, right? The second conclusion, so in addition to, you know, there may be a need for policy around other service categories or how you think about the definition to ensure that it's reasonable to continue to chase that 12%. Kind of the second thing I wanted to highlight is that the fact that it's such a complex dynamic across all of the different service categories, it would be interesting to see how payers are approaching this, approaching achieving the primary care expenditure target, which is why it's great that some of your fellow committee members are able to speak to that, because actually achieving it without driving up significant expenditure, which could drive up premiums or require significant additional investment from the state, understanding what that dynamic is just going to be difficult because there's too many moving pieces. So just keeping that front of mind as we think about some of these complex issues is going to be important. So those two key takeaways here. Sorry, Tracy, did you have another question?
Nope, sorry, I forgot to unraise my hand.
No worries. No worries. Okay. If you could go to the next slide, please. So again, we're just trying to build context around the implications of this policy. It's clearly something that's going to impact your delivery system, so it's important that you have robust, realistic, feasible policy. Some of the key things that you can derive from these examples are that you have to understand the natural underlying pattern of utilization changes over time for both primary care and other services when thinking about the feasibility of making progress on the 1%. It'll be important to understand the natural underlying rate of price changes for other services. And then being able to account for policy-driven expected changes to utilization of primary care services and other services. So to understand robustly what the factors are that allow you to achieve the 12%, you would have to understand all of these things. And ultimately, it does raise the question of if that's even realistic. To some extent, you may need to have the flexibility not to have a hard target with a hard consequence, but to allow the plans to have a plan like they did in Oregon. So, you know, there'll be a lot to think about there. If you could go to the next slide, please. Okay, so key things to take away from this. Again, we're just trying to close the gap between some of the concepts that were raised in the last meeting and what some of the examples of how those actually play out are. The first point here, so small increases in the percent of total spend require significant increases in primary care reimbursement when holding utilization and total expenditures constant. Total expenditures include many moving pieces. Kind of an interesting implication here is that increasing primary care reimbursement would likely increase utilization of primary care services. Increasing primary care access would decrease utilization in other service categories. And there's dynamic interactions between primary care or excuse me, the dynamic interactions impact primary care percentage of total expenditure. And as Oregon also noted, the implementation of payment changes will vary by payer. So I just want to take a moment and ask, so for those of you that had raised questions within these different domains in the last meeting, did these clarify, or would additional examples be helpful, or are there any other questions that kind of flow from these examples that you wanted to tackle today? DC?
Hi, Shane, thanks. And thanks all for bringing these data. Do we know, I'm obviously totally support moving all possible ways that meet our goals here, but I'm curious about that second sub-bullet under ideally, increasing primary care access would decrease utilization of other service categories, which totally makes sense in principle. Are there, is that what actually plays out in fact in the places where this has been instituted? Is that known?
That was one of the questions I was trying to get at in asking the asking Summer and Amy. They highlighted that it's difficult to answer that question in part for some of the points that are made here as well, which is that there's a lot of moving pieces that would influence that. It's really hard to isolate a single policy when you're looking at all of healthcare utilization and expenditure and attribute an impact to it. There are, I know I have seen studies that talk about the relationship between primary care and utilization of emergency services and inpatient services. And I think that those are more intuitive, but creating that link between an aggregate expenditure target and this, I don't think we would be able to do that.
Okay, great, thank you.
Any other questions before we move on? Tony?
Yeah, this is just, as I listened to especially the key takeaway on the small increase in percent of total spend requires a significant increase in primary care reimbursement. I had to kind of interpret that for myself. It seems like a 1% increase in total spend allows for that 40% increase in primary care reimbursement, which allows for the team-based care and all the others. I came away from that. If you didn't understand how all of this works, you would get the sense that the same services were provided and you're just reimbursing the providers more. And I think we need to be careful about how we present and use these numbers because, certainly if we're farming this data out to others, we would want them to understand that 1% that leads to a 40%, 1% of total that leads to a 40% increase in primary care spend allows for the holistic team-based care that we're really shooting for, which is increased utilization, even for the patients that are already being seen. Hopefully you'd also increase access, particularly among underserved. But I just wanted to point that out because I didn't think it really came through too well in the presentation, if that makes sense.
That's a good call out. With the bullet here, so under ideally increasing primary care reimbursement would increase utilization of primary care services is exactly to your point. For the example, just kind of the key point is that it's really difficult to isolate all of these moving pieces and get the concept clear. So we have to reduce it down to what is almost an absurd assumption that you're holding both utilization and all other expenditures constant. Like that's absolutely unrealistic. So if you were to put this concept into practice and actually have a more robust multi-step example versus one that's just pretty rudimentary to get the point across, the amount that you would have to increase the amount that you would have to increase payment rates to achieve the 12% target would be less because an increase in reimbursement is also going to drive an increase in utilization. So that 40% might be 20%, it might be 10%. It's not clear, but what is clear is that you would expect there to be a fairly significant difference between the 1 to 3% and what's happening on the primary care side. So I agree with you, and I think we can be careful about framing that. It really is because there's so many moving pieces to get to just a bare bones example. You do have to make kind of wild assumptions, so we'll be careful about that.
Right, and I appreciate that. And just real quickly, I think it also speaks to the need to really focus on that non-claims based and shifting away from fee for service is integral to this. If you don't do that, it just doesn't work. And I think this highlights one reason why.
Yeah, absolutely. Any other questions or comments before we move on to the next topic? All right, seeing none, if you could go to the next slide, please. So one of the other things, and some questions earlier kind of highlighted this. We're not going to make a decision on this today, but we do want to make sure that this is top of mind, particularly as we transition into discussions about including codes and excluding codes, which will be coming soon as the data analysis approaches completion. But ultimately, you're going to want to pick either a narrow or a broad definition. Because it doesn't actually make sense to have two standards applied simultaneously. Essentially, what would happen is that whatever the lower standard is what's applied. So at some point, we'll need to make a decision on that. So when thinking about this, there's really two specific policy concerns that come to the table. So the first is that to achieve a 12% target under a narrow definition, investments focused on that narrow set of providers would have to be greater. So fewer providers would see an increase, and that's just the function of how the math works. The second piece is true as well. So the magnitude of investment directed to a narrow set of providers would have to be good. I guess I combined both. Sorry about that. So when you ultimately decide on who's included in the set of the definitions, it does have a fairly significant impact on how the policy rolls out, because you're telling payers that they need to direct greater investment towards a specific set of providers, and the magnitude will have to be greater or lesser depending on how broad that pool is. So it's a distribution impact for sure. If you could go to the next slide, please. Just as a reminder, again, we're not voting or changing or doing anything today, but just as context. So where there's a key difference between narrow and broad is really on who's included in the definition. And this, again, is just a reminder summary that this is the subset of providers that are not included in the narrow definition, but are included in the broad definition. You've all seen this before, but we're just trying to keep these concepts top of mind as we start talking about some of the policy implications. If you could go to the next slide, please. So there's the other implication that's fairly significant is that if you're using a narrow definition versus a broad definition, the distance to your target's going to be greater. This is just a little snapshot from the 2019 OFM report, and here you can see that they have the narrow and broad broken out by the different insurance sector segments. So commercial under the narrow, they were at 4.5%, at the broad at 5.7%. So there is a spread there that's impacted by the definition. And again, going back to these small numbers translate into big numbers when you start to look at the impact on individual providers. This is worth keeping in mind. It's both worth keeping in mind from a feasibility perspective, from a how long it would take to get to the target perspective, but also on just what the relative difference in magnitude is. Another key thing I just want to remind everyone, I said this before, but it bears repeating, is that the OFM report didn't include non-claims based expenditures, and your definition and your methodology does. And so you would expect, plus or minus some of the changes in the actual definition, likely a bit of a level shift from where these statistics were to what you would see for your own. And then again, as a reminder, to see what the expenditure, what your primary care expenditures are under the definition that you develop, because this comes from payers and there's a non-claims based component, you won't be able to see where you're at until after the next data call. So you won't have complete information for a while. So that just bears keeping in mind as well. All right, if you could go to the next slide, please. So just to summarize again, so the primary care definition will directly impact investment strategies if a 12% expenditure target is adopted. The impact could vary depending on whether the payment model is fee-for-service or under an alternative payment methodology. Under a blanket fee schedule increase, providers outside of primary care may benefit from the increase. Under an APM, investments could be targeted to primary care while capturing the entire care team. We don't know how far apart the two definitions will be, again, until the data is collected and run through essentially what is the new algorithm for identifying primary care expenditures. You won't be able to see that. And again, no decisions today. We just want to keep top of mind that this is a key decision that we need to be thinking through and is going to be relevant as we have discussions with other states, but also as we start to look at the data results from the code definition set in the future. So, all right, I think that's it for this section. Are there any other questions or comments about broad or narrow? Again, just keeping it top of mind, but any comments certainly welcome now. Okay, the last piece here before we hand things over to Michelle is just a reminder about making care primary. We've talked about this a little bit in the past, but we want to make sure that we get a reminder out, and we ask that you know, as leaders in your industry, that you're sharing this information wherever you can. So making care primary is Medicare's primary care model. It's operated in 8 states, including Washington. The program will run for 10.5 years. That's from 2024 to 2034, with the same cohort of providers. And I want to emphasize that the same cohort is maintained for the duration of the program. To be a part of the cohort, eligible providers have to apply. For the program, there's a focus on improving care management, care coordination, and integration. Supports for value-based payments and equitable access through additional investment in primary care are a core part of the model. And also importantly, it aligns public and private payers. Washington payers are exploring how to align current efforts with the MCP program, the Making Care Primary program. I think Oregon really highlighted why it's important to have that connection, and that was echoed by committee members as well. But this is really a unique moment if you think about all of the stars aligning. So if you have the federal government that's stepping in to make an investment and provide supports, having significant investment in quality, offering alternative payment methodologies. You've had your multi-payer collaborative in the state working towards offering aligned payment models with this model as well. You know, this really ties into what you're going to be advancing as a policy recommendation in the future as well. So it's really quite a unique moment. If you could go to the next slide here. So this ties back to a single cohort for the federal model going forward. The application is out and the iron is hot. So they're accepting applications from September 4th through November 30th. And this is a one-time onboarding. So again, if you or your organization are interested, now is the time to start to look at this. And also, you know, to serve as a mouthpiece for the community and let them know that this opportunity is available because it is one time for the federal component of the model. So any questions or comments on Making Care Primary? Okay, great. Thanks very much. And I believe that's it for me. And I think we're handing things back to actually to Michelle Coslet.
Yeah, it has a closing slide, but we're not closing. So Michelle, if you are prepared to give your remarks, we would love to hear. Yeah,
no problem. So first, I just want to state that my remarks are based on my reading of the Rhode Island regulations, and then my conversations with a colleague who works in the Northeast part of the country, and oversees the state-run programs related to value-based care and primary care spend. So for the benefit of the committee, just a couple of interesting notes about the Rhode Island regulations themselves. So number one, they did increase their primary care spend back in 2009. They started on this road. They started with about 6%, 6.3%, and now they are at 10.7%, which is the target that fully insured plans must maintain. Out of the 10.7, Rhode Island regulation states that at least 9.7% of it has to go to direct reimbursement, either claims or non-claims based, to providers. But the other 1% is related to administrative fees that plans are required to pay to the state that help fund their IHE, so their state health exchange, information exchange product. And then also it helps support the administrative costs for the state running the PCMH program. So they do PCMH type of certification to inform plans where practices are at in terms of their road to transformation, being able to accept risk. So that 1% UHC pays into, and that goes towards the target for those administrative costs. In addition, the other mandated payments that goes towards the 9.7, the direct reimbursement, is for practices that do meet PCMH or either qualified or they're making steps to transform. And again, that's determined by the state. Plans are required to make PMPM payments to support those efforts, although they don't dictate the amount of the PMPM payment that's negotiated between the payer and the practice. So that is part of what also helped UHC achieve the 9.7% that's required for the direct spend. Largely, the way we achieved most of it was through the advancement of value-based payment models. We did increase the use of those models in the state. So those shared savings and the care coordination payments that are embedded in those models both contributed to helping achieve the primary care spend. And then in addition, if UHC wasn't meeting the target, or if we needed a little bit more lift to meet the target, we did offer grants to practices and systems to pilot or set up new alternative payment initiatives, or initiatives to help manage cost and support their primary care transformation. So like I said, between a combination of those, downside risk contracts, upside risk contracts, and these grants, we're able to achieve that primary spend target. A couple of other caveats, just to kind of get back to some of the points that Shane was bringing up. In Rhode Island's target, they do include pharmacy net of rebates, which I agree. I think it was Tracy who brought up, some of the huge cost increases we've seen in pharmacy, and including pharmacy in the denominators, it can really lead to a lot of fluctuation in primary care investment, because if you're those costs can fluctuate greatly each year, and then it just makes it more difficult for payers to meet the target because of those those high fluctuations. And then in addition, which I think was also alluded to earlier, Rhode Island does control hospital trend, which is a big portion of our overall healthcare expenditures. But they tie increases. Plans are only allowed to increase. They usually tie it to like a CPI urban index. So the OIC determines what kind of caps what those trend rates are for hospitals. So that kind of helps mitigate a little bit of the trend. And I will say that that's really important too. I mean, especially now in this environment, hospitals are just, I think we've all seen the news. They're really having a hard time right now, and we're getting requests for double-digit increases. So it's kind of a crazy time right now in terms of healthcare. And then just getting back to some of the other questions, whether or not we saw total cost of care declines. The answer to that was not really. We did increase our use of value-based payment models. We did see an uptick in the use of downside risk models. But without a direct offset elsewhere, it's really going to be difficult to truly, to bring down the total cost of care. without an additional offset to that additional primary care investment. And, you know, a lot of the value-based payment models really now are more trying to mitigate trend. I mean, you're always going to have inflationary pressures. So it's really more of trying, again, like I said, mitigating the trend is what those value-based care models go after. So that's kind of the high level experience. Are there any questions? Okay.
Thanks very much, Michelle. Appreciate that. And John, I think you were going to wrap up the meeting, but I can too. Up to you.
I defer to your expertise.
Sure. All right. Well, I'll take it. Go with it. So thanks everybody for coming today. Thank you, John, especially for taking Judy's place while she was gone and co-chairing. And as usual, the recording and summary of this meeting will be posted shortly on the committee's website. It was really great to hear from Oregon. Again, I feel like this was a really rich discussion that we had throughout. Flowed well with Shane's context. I think we followed up nicely on some questions that we had from the prior meeting. We're still in the process of nailing down our exact agenda for the next meeting, to be completely transparent. So, but we are, as Shane alluded to, moving towards discussing the data analysis that we've been acquiring. So depending on where we are with that, we'll see what we include next time, but we hope to get to that shortly. And there may also be some more information upcoming as far as HCA's work with multi-payer work aligning with the Making Care Primary. We might have a presentation on that, and work's coming up soon. So things to look forward to. And our next committee meeting will be on September 28th at 2 p.m. And I look forward to seeing everybody then. Thank you so much for attending today, guys.